This week we are learning about neurocognitive disorders within the DSM-5 TR. Please take the time to review it. You're going to see it. I do not manage a lot of neurocognitive disorders since we have a gerontologist that does that. And sometimes we have neurology that does it. So I see people with neurocognitive disorders, but I typically don't manage their meds. I'm aware of their meds and how to utilize their meds. But we have other people that have been managing it. So just be aware your community may have a gerontologist that is doing all the neurocognitive people. I manage their depression and anxiety, but not necessarily their neurocognitive disorder. So there are neurocognitive domains that you need to be aware of. So please read through these. There's the attention. So look at mild and major, executive function in mild and major. Look at learning and memory, language, perceptual motor. Please, I implore you, read through this. It will make sense and will be well worth your time. I won't read it to you. And then we have social cognition. Please read the differences. Please listen to the Toussey and Fitzpatrick lecture because we go through some of the differences between mild and major neurocognitive disorder. Delirium, probably as an RN you've seen delirium, and maybe as an FNP, a disturbance in attention over a short period of time, disturbance in cognition. Criteria A and C are not better explained by another pre-existing or evolving neurocognitive disorder. The evidence from the history, physical exam, or laboratory findings that the disturbance is a direct physiological consequence of a medical condition, substance intoxication or withdrawal or exposure to toxin, or is due to multiple etiologies. Delirium, they need to be evaluated quickly. I send them to the ER to be evaluated because I don't have openings on my schedule for 3 months. It's hard to evaluate delirium without seeing a patient, and even an outpatient. They should really have instant labs to figure out what's going on and management to keep them safe. So delirium can be acute or persistent, lasting weeks or months. When I was a nurse in a nursing facility that was a skilled nursing facility, so we had our long-term people and then we had our short-term people. I had a person who went for a knee scope, completely normal, 50-some-year-old female, went for a knee scope and then came out of the knee scope completely delirious, and it lasted weeks, just weeks. She was just delirious. And when she came out of it, she was so embarrassed because she did some wild stuff. And when she came out of it, she was just so embarrassed, and it was weeks. I'm thinking almost over a month she was delirious. And that's why I warn people about surgeries, because she had a history of MS. And I don't know if like the anesthesia affected whatever happened. She was just not good. Her stay with us was long to get her out of that. And they can have hyperactive. That was her. She was just throwing things, swinging her arms, screaming, wouldn't cooperate. Or you can have hypoactive, or you can have mixed level of activity. Substance intoxication delirium. You will see this. I've had people take too much of their Adderall and then create some silly, became delirious on it. I had a coworker whose person created some silly on a whole bunch of Adderall. They were just delirious. Just, is it substance intoxication delirium, or is it stimulant intoxication? You could give them both. because they are both, but it happens. So then it lists, coding wise, what substances you could list. Here's more of those substances. Also, alcohol can create some delirium and withdrawal. So be aware of that you could code for that. Delirium due to another medical condition. I've seen someone delirious with really high blood sugars. And then you can code for multiple etiologies. Other specified delirium. This is an interesting one. Subsyndromal delirium, a delirium-like presentation involving disturbance in attention, higher level thought, and circadian rhythm, in which the severity of the cognitive impairment falls short of that required for a diagnosis of delirium. So yeah, if they're not sleeping, they're going to have some stuff go on. They can get a little delirious when they're not sleeping. So just be aware of that. Unspecified, if you just don't want to specify, typically it's the ER given that diagnosis. So we have major neurocognitive disorder. I'm sad that the DSM starts with major instead of mild. Be easier. I guess I could have switched the slides around, but I guess we'll go with what the DSM has in there first. Major neurocognitive disorder. Just be aware, note, each subtype listed has specific diagnostic criteria. So I'm going to go over the major neurocognitive disorder, but I'm not going to go over each specific subtype in detail. You're grown, you can read. I definitely recommend that you review those. So evidence of significant cognitive decline from a previous level of performance in one or more cognitive domains. The domains we talked about, please read those. And they list on there mild and major, so it really helps you out. If you're really stumped and you'll be managing dementia, just be aware of the difference between mild and major. Concerns of the individual, a knowledgeable informant, or the clinician that there has been a significant decline in cognitive functioning. A lot of times family members are in your office telling you or giving you phone calls of what's going on. Of substantial impairment in cognitive performance, preferably documented by standard neuropsychological testing. And I refer out for psych testing. I want them on my side, and it's part of it. So refer out for major psych testing. Don't just be giving somebody a major neurocognitive disorder label without getting psych testing. Or in its absence, another qualified clinical assessment. Go get that psych testing. You want it on file. Find out who your neuropsychologists are and know how to refer. The cognitive deficits interfere with independence and everyday activities. It interferes. So that's the difference between mild and major. Major, it's interfering. These are the people going missing. It's not a good deal. It's interfering their life functioning. They're leaving the stove on. They're starting fires. They're not paying their bills. They're not changing their clothes. They don't know how to use their washing machine anymore, fill the dishes. Is not part of delirium. Not explained by another mental disorder. So schizophrenia has a lot of cognitive deficits, quite a bit of deficits, and actually bipolar when they're depressed or starting to hit a mania or hypomania, they have a lot of cognitive deficits, and so does major depressive disorder. So you have to rule out those prior to this, a major neurocognitive, and then we have the specific subtypes. And then we have mild, moderate, and severe for it. And then other coding and recording procedures. And then we have the mild neurocognitive disorder. So evidence of modest cognitive decline from a previous level of performance in one or more cognitive domains. So those are the domains that were listed in the beginning. So definitely know those domains, review those domains, be aware of those domains. concern of the individual, a knowledge of informant or the clinician that has been a mild decline in cognitive function, and a modest impairment in cognitive performance. Preferably do it. It's preferable. Documented by standard neuropsychological testing. Jump on that bandwagon, get them on neuropsych schedule, get this figured out, get somebody there to get a baseline, because I have seen people progress rapidly. So get that baseline, be aware of it, pay attention to it. The cognitive deficits, the difference between mild and moderate is the cognitive deficits do not interfere with capacity for independence in everyday activities. So be aware of that. That is the difference. It's not interfering with their everyday activities. They can stay at home. They can do their things. But it's not interfering with their independence in everyday activities. And it's not because they're delirious, and it's not because of another mental disorder. And then here you can specify if it's due to some of these diseases. And then some coding without behavioral disturbance, with behavioral disturbance. So that's the biggest thing that you're going to get is the behavior disturbance. You know, as outpatient psych, if they have a gerontologist or neurologist who's managing their dementia, you're going to get the call about behavioral disturbances. So just be aware. Be aware to be on the lookout for the reason they're having behaviors. I tend to not want to prescribe meds for behaviors because a lot of times it's triggered by something. So just be on the lookout for that. Here's coding procedures, additional coding procedures. And then here's major or mild neurocognitive disorder due to Alzheimer's disease. So you can code if it's probable Alzheimer's disease or possible Alzheimer's disease. Again, you're going to be in communication. You're not the one diagnosing Alzheimer's disease. Get the neurologist on board and figure out if you guys want to go with this. Additional coding. And then major or mild frontal temporal neurocognitive disorder. See how it's different than the Alzheimer's one? So be aware, read through these. There's a lot of them. Just read through them. I'll kind of skip through because you have the ability to read. The biggest with the frontotemporal neurocognitive disorder is behavior inhibition. That's because it's the frontal lobe, kind of like those kids with ADHD. They just can't hold themselves back. Neither can these peeps. Apathy or inertia, loss of sympathy or empathy, compulsive or ritualistic behaviors, dietary changes, decline in social cognition and executive abilities, and also the language variant. So Bruce Willis, he's made the news. He has made frontotemporal neurocognitive disorder primetime because he has it. And it started with the language variant. He just, the family came out and said he had aphasia. And then later on, they came out and said he had frontotemporal neurocognitive disorder. And now he's like completely not talking at all, it sounds like. And he's just got odd behaviors that he does. So frontotemporal neurocognitive disorder, interesting disorder for sure. And then more coding stuff for it. Then the Lewy body, fluctuating cognition with variations in attention and alertness. Totally saw it in the nursing home. They were there one day and not there the next day, and the family will tell you that. And then recurrent visual hallucinations that are well-formed and detailed. The hallmark is animals. I'm telling you, the amount of people with Lewy body that are seeing cats run by or mice run by. So when I get a patient, you know, because I ask about hallucinations in every visit, every single visit, I ask people if they're having any hallucinations. And when they tell me they saw a cat ran by or a mouse run by and they're older, I'm like, oh, that triggers my antennae. to ask them how their concentration and their memory has been, because we may be progressing to a Lewy body, so be aware of that. Spontaneous features of Parkinsonism with onset subsequent to the development of cognitive decline. Suggestive diagnostic features, rapid eye movement, sleep behavior disorder. I have a couple people with that, and I keep Lewy body in mind, especially if they say they've seen animals run by. And not explained by something else, and here's some coding stuff. Then we have major or mild vascular neurocognitive disorder. After a cerebral vascular event, prominent decline in complex attention and frontal execution function, presence of cerebral vascular disease from history, and not explained by any other issue. And some coding issues. Here's some coding. And then be aware, some people will have a neurocognitive disorder due to traumatic brain injury. Within that traumatic brain injury, they had to have had one or more of the following: loss of consciousness, post-traumatic amnesia, disorientation and confusion, neurological signs. I ask at every initial appointment if they've had a concussion, because that is important for the future if they start having any memory concerns, and for you to keep an eye for neurocognitive issues. And here's some coding. And then here's classification of traumatic brain injury severity. You can look at that. And then substance medication induced major or mild neurocognitive disorder. So the criteria are met for major or mild cognitive disorder. Not delirium. That involves substance and medication and duration and extent of use are capable of producing the impairment. Hopefully you're not the one given that medication, and if you are, get them off of it, because we don't want them to have a cognitive disorder. So be aware that there is a substance medication-induced major or mild neurocognitive disorder. And coding. So alcohol is probably the most notable one to cause a neurocognitive disorder, so be aware of that. And then major or mild neurocognitive disorder due to HIV, so they have to have HIV and have cognitive issues. Prion disease, never seen it. Outpatient, I'm sure it's in bigger cities. I'm in a small town, so I probably will not see it, but it could be. So there are motor features that's different of prion disease, such as myoclonus or ataxia or biomarker evidence, not attributed to another medical condition. And here's some coding for that. And then we have Parkinson's disease. You'll probably see this major or mild. And so insidious onset and gradual progression, not attributed to another medical condition. No evidence of mixed etiology. And Parkinson's disease clearly precedes the onset of the neurological disorder. These are the people that I was taking care of on the long-term side of the nursing home, were the major neurocognitive disorders due to Parkinson's disease. And some coding. And then Huntington's disease, I've only experienced one person with this neurocognitive disorder. Huntington's is hard. There's clinically established Huntington's disease, and they're also having cognitive disturbances. And then major or mild neurocognitive disorder due to another medical condition. So multiple sclerosis would be one of them, with behaviors, without behaviors, so just be aware of that. Here's some coding. And then there is major and mild neurocognitive disorder due to multiple etiologies. So I like the example that they give, the Alzheimer's disease with subsequent development of vascular neurocognitive disorder. So that might be found, you know, they end up in the ER for a fall and they get a brain scan and found to have vascular disease on there. So just be aware of the incidents that you can have major and mild due to multiple etiologies. Here's some coding for that. Then as always, we have an unspecified neurocognitive disorder. So just be aware of that as a coding differential. So lots to learn this week within the cognitive disorders. Review Tuesday and Fitzpatrick on how to do the mini mental status exam, the MOCA, and the other instrumental tools that are on there. How to rule out delirium, how to rule out major cognitive, mild cognitive disorders. What is the difference between major and mild? Know those domains, and I think you should be set with your boards and with your exams with knowing that information.